talk today is on diabetes educator and COVID-19 pandemic. Before I start my talk, do allow me to share my career journey as a diabetes educator, and then why do I stay in diabetes education for 33 years. I started my career, I'm a nurse by profession. I started my career in 1976. I qualified as a certificate of nursing from Assunta School of Nursing. At the time, there was no diploma in nursing, no degree in nursing. In 1982, I did my midwifery training. Not that I'm really interested in midwifery, but at the time, at the early years of nursing, we have to have a certificate in midwifery before we can go for any postgraduate training. And in 1987, I left the Ministry of Health to join a private hospital. And between 1976 to 1987, I was in the Ministry of Health most of the time. I was doing some medical nursing, surgical nursing, pediatric nursing, maternity, ENT, and general nursing. When I joined the private hospital, a small private hospital in Malacca, I was asked to start a diabetes education service and a renal dialysis unit. So my boss at the time actually sent me to the Nova Scotia Diabetes Center in Halifax, Canada for attachment posting. At the time, I have no idea what is diabetes education, but it was a very good eye-opening. And at the time in Canada, there was no certification of diabetes educator program yet. So it's mainly an attachment posting where I follow the diabetes nurse, I follow the dietitian, and we had to conduct group classes over there. Almost every week, there are group classes for people with diabetes. And remember, I also have to teach in the group classes. And I remember the topic that was given to me to teach the subject was, what is diabetes? And in the class, they are professor of university. From university, they are lay people. So it was a real experience for me. When I came back from Canada, when I was in Canada, I also have to learn about renal nursing so that I can start a renal dialysis unit for the hospital that had employed me. And our hospital was the first diabetes education unit and the first renal dialysis unit in the southern region of Malacca. From 1987 to 2012, I was mainly doing a lot of diabetes education and renal nursing and general nursing. Then in between that period, I was also attending a lot of short courses in Malaysia, overseas. And in fact, I attended one of the 1 week intensive diabetes courses in the University of Toronto. And that was another eye-opening of showing us what living with diabetes is all about. And at the time, I also attended a lot of international meetings, especially the International Diabetes Federation Congress every 3 years. In fact, I follow them going around the world. And during this conference, I will have the opportunity to meet a lot of diabetes educators globally, especially from North America, from Canada, from Europe, from Australia, that have actually given me a lot of insight of what diabetes education is all about until today. We are still good friends. And at that time, I was really admiring them, that they know so much of diabetes. They know so much of diabetes education. And most of them will have the title called Certified Diabetes Educator. And that was my dream. I wanted to join them in this certification. And in 1994, I managed to find a certification course in Australia at the Prince Alfred Hospital, Sydney. In fact, it was Prince Alfred Hospital, Sydney, North Shore, and St. Vincent. These three hospitals combined together to provide us this training. And at the time, my classmates were not only nurses, they were dietitians, they were pharmacists, they were podiatrists from Australia, from New Zealand, from Hong Kong. And there was an exam, I remember. And I was very happy. I came out to be the top 3. After I returned, I continued my work in diabetes education, as a diabetes educator in the private hospital. And in 1995, I saw an advertisement in the newspaper, Bachelor of Nursing degree. Well, I said, wow, this is something that I should study. So I joined the Anglia Polytechnic University. The time the study was done in Malaysia. Every 3-4 months, we go to Kuala Lumpur. It was a part-time study for adult nurses. We go to Kuala Lumpur for a week of study, then we come back and do our own assignment. So it took us, since it's a part-time, it took us 2 years to complete the degree course for nursing. And being the second batch in the country, our classmates were a lot of, the time it's called matron, from the Ministry of Health, matron from hospital, of various hospitals, and all of us just wanted to bring up the standard of nursing. And it was very good in the sense that nursing degree in Malaysia, I find that nursing degree generally, irregardless of your background in nursing, it is important that we are allowed to do subject that is related to our field. Just like one of the modules that we have to do is called teaching and learning. So I prepare my assignment all about either renal nursing or diabetes nursing, and I passed. So I continue my work. And in 2001, actually, as I was working as a certified diabetes educator in my little hospital in Malacca, I always see my patients are having a lot of complications. Then I asked myself, why? I wanted to know, why is it they are having complications? Is it a lack of knowledge? Is it a lack of skill? Or is it something else? So I signed up with the Master of Nursing with University of Adelaide. Again, it's a part-time study. And my thesis was the relationship of health belief and complication reduction practice of people with diabetes. So is there a relationship? Is it why people not taking their own self-care seriously? Is it because of their health belief? And then during the time between 1997 to 2003, I was also had the opportunity to travel with a wealthy, one of my patients who had diabetes and on dialysis to Australia, because her last wish, she was about 88 years old. Her last wish is to visit the children in Australia again. So I followed her to the dialysis center, and it was another eye-opening. In Malaysia, usually nurses with master degree, with PhD, they are always in the teaching college. But no, overseas they are different. They are working in the clinical field. So with that, when I came back, when I graduated from Master of Nursing, I started to think, why don't I carry on? And because I have a burning clinical question with me, very often until today, if somebody with diabetes coming with very high sugar reading, either the nurses or the doctors, all of us will look at her, will look at the patient. What did you eat just now? Why was your sugar so high? As if the fault is all belongs to the patient. So for my Doctor of Nursing that I continue with University of Adelaide, my thesis was self-care practices of poorly controlled adults with diabetes in Malaysia. I wanted to find out, when their blood sugar is very high, is it because of patient's fault or is it because of something else that contribute to it? And to my surprise, my thesis, the finding is, it is not just the fault of the patient. We, as healthcare provider, are equally guilty for it because of medical inertia, because the way we speak to the patient, because we couldn't motivate them, because we have not provided them with the education that they need. And it is also the healthcare system. In a crowded waiting room, if in a room with 2 or 3 consultation table where the people sitting, the doctors, the nurses, seeing the patient, if you are a patient, will you tell your healthcare provider your problem that you face in living with diabetes? Of course, the scenario is better now. Most of us have our own individual consultation room. In 1987, when I came back from Canada, I have the same problem. My consultation room was next to the procedure room, which the wall separated it was 6 feet high. So everything that is going on, and my room was only 4 feet times 8 feet. And everything that we discuss in the room, the people in the procedure room can hear everything. So with my study as a doctor of nursing, I managed to find the solution, the reason why people with diabetes we poorly control. At least until today, I'm still practicing what my research has shown it to me. So when I finished my diabetes, my Doctor of Nursing, I graduated in 2009. In 2010, then I was thinking to myself, okay, I have lapsed my certified diabetes educator for a long time from the Australian Diabetes Educator Society Association. It's time that I should get my re-credentialing back. So of course, I got to sit for some assignments, some case study, and until today, I have the opportunity and I'm very happy, I'm very lucky that the Australian Diabetes Educator Association still award me with the credentialing diabetes educator status. And in 2012, I was given the privilege by the IMU to join them in the healthcare as a diabetes nurse specialist to work together with the endocrinologist there. And as I was there in 2014, again, I was given the privilege by Professor Peter Polk, who is no more with IMU now, who was a vice president then, to start a curriculum to train diabetes educator at the postgraduate level. So we started, a group of us started from different disciplines. We started the curriculum, got it approved by MQA, and we grew out the curriculum in 2019. So in 2008, I was employed by IMU faculty as the senior lecturer in diabetes management and education program. That is my journey of how I become a diabetes educator. So what keeps me in diabetes education for 33 years? I've been asked this question many, many times. On reflection, there are 4 reasons that kept me going. Number 1, uniqueness of the case that I encountered in my practice. Now, diabetes is the same. Type 1 diabetes, type 2 diabetes, gestational diabetes. The signs and symptoms are there. The investigations are almost the same. The treatment are the same. But it is the uniqueness of the person behind the diabetes. To illustrate this point, allow me to share with you the story of an 11-year-old boy with type 1 diabetes, admitted in the hospital for diabetes ketoacidosis, on short form DKA. DKA is an acute complication of diabetes with high blood level, very high blood sugar level, high blood acid level, and severe dehydration. If it is not managed early, it can be dangerous. So the diabetes educator who attended to this boy have done her assessment, and she found that there's no knowledge, no skill deficit in this boy regarding diabetes care. Further probe into his social life, noted that his father passed away last year. The mother already left them many years ago. So now he has to stay with the grandmother and the uncle. And the uncle is the one who brought him in for admission. As compared to another boy, 11 years old with type 1 diabetes with a stable family environment. The diabetes education approach for these 2 boys are entirely different. For the earlier boy, it is important that us as diabetes educator support him in his emotional turmoil of losing the father, of losing somebody he has been close. Not that the grandmother and the uncle are not looking after him, but he has lost a father. Rather than teaching him how to manage his diabetes. And in 1994, when I was doing my training in Royal Prince Henry Hospital, Royal Alfred Hospital in Australia, one of my lecturers actually published a book. The title of the book is, "You Must Get Through to the Other Side of the Face." If you don't get through to the real reason of the problem, be it lack of knowledge, is it a cultural problem, is it a religious issue, is it a psychosocial issue, or is it a health belief issue, we would have problem managing diabetes for the people. Number 2, challenging. Why is it I find it challenging in my career as a diabetes educator? Now, I put it down there. Diabetes is one of the most demanding medical conditions. I'll tell you why. Diabetes always comes with the other 2 siblings. We always call them the 3 siblings. Diabetes, hypertension, high blood cholesterol. For hypertension and high blood cholesterol, yes, healthy lifestyle is important, weight loss is important. But as long as you take your prescribed medicine, usually your blood pressure and your cholesterol can be controlled. But not in diabetes. managing diabetes is not about taking medication. Everything you do every day affects your blood sugar level. The food you eat during MCO time, we have to add in. But other times, you may have kanduri, you may have wedding dinner to attend, you may be eating out with friends, your daily activities. Now we have been locked down. So our daily activity is very different from non-MCO time. If you go on holiday, you'll be walking very much more than what you do here every day at home. Because when you go on holiday, you're not going to stay in the hotel. You're going to go and sightseeing. When you go for preparing for a sports event, how about your mood? How about the mood of a person with diabetes? When you're happy, because you got bonus from last year, because you pass your exam if you're a student. But when you're sad, because you get scolded, you have conflicts in your workplace, you got a letter from the boss to say that you're retrenched. Hormonal changes. If you're a lady with diabetes, pre-menstruation, your blood sugar always go higher than other days of the month. When you're sick, you have hormone, your hormonal changes will push up your blood sugar. So everything in your life, physical, emotion, hormonal, affects your diabetes, your blood sugar level. That's why I say diabetes is one of the most demanding medical conditions. And until today, many people with diabetes go for their appointment every 3 to 4 months. And some may be lucky being referred to a dietitian or diabetes educator to learn how to look after your diabetes. But if you add up the total time of this appointment, it's usually less than 12 hours in a year. But 1 year, we have 8,760 hours in our life. For people with diabetes, they live 8,760 hours of living with diabetes. So other than those times that you are in the healthcare environment, you've been left alone. That's why I say, I put down here, more than 95% of the lifespan by people with diabetes are outside healthcare environment where you look after yourself. To decide what you want to eat in kanduri, to decide what you want to eat when you go out with friends. And a lot of them are working adults. So you have to decide how you will prevent yourself from low sugar. If the meetings, or we have lots of meetings, if the meeting is stretched to lunchtime where you have no lunch, you have to decide when you want to take your medication. If you have side effect of medication, what do you do about it? And you have to decide when to take your injection. Just to illustrate this point on injection, let me tell you another story. I was referred a case about 2 months ago. I think he is about 40 plus years old, and he wasn't very old. He's middle age. Long duration of diabetes, poor glycemic control, had a lot of complications. So the doctor has prescribed what we call a basal insulin. That means once a day insulin. The doctor told him, and the pharmacy who dispensed the insulin to him, told him that please inject your insulin before sleep. And then he was sent to me to show him how to start blood glucose monitoring. But I usually will go through the whole process of diabetes education with my patient, and not just to teach them blood glucose monitoring. And I found that he's a security guard. And he worked 12-hour shift. 7 in the morning to 7 in the night, there is a day shift. 7 in the night to 7 in the morning, there is a night shift. So in a week, he has three, he has 3 days of day shift, 2 days of night shift, and 2 days off. So injection before sleep. When he's on day shift or when he's during his off day, before injection, before sleep can mean 10, 11 o'clock in the night. But what about when he's on night shift the 2 days? Before sleep, when he come back at 7 a.m. in the morning, then he may have his breakfast, he may get washed out. So before sleep is 9 to 10 o'clock in the morning. Isn't that confusing for the people with diabetes? These are just a few examples. So as diabetes educator over the years, I ask myself, how can I help my patient to have more knowledge on how to live with diabetes, with their life with diabetes. And if we come to number 3, rewarding. What is it I find rewarding in my career as a diabetes educator? When a person has diabetes, yes, just like having your blood pressure, having your cholesterol, you have to take medicine, and those on injection will have to take injection. You have to follow the dietitian with a healthy life, healthy eating. You have to exercise. You have to do monitoring your blood sugar, and you also have to do daily check of your feet. But that is diabetes regime. But life is not about everything about diabetes. In a person's life, if you live in Kuala Lumpur, Johor Bahru, in area that there is a lot of traffic jam, the traffic jam will stress you. So might be a natural disaster like flood. Life is never just peaceful like that. There are conflicts within the family members. There are conflicts with your colleagues in work. So a lot of people with diabetes find that it's just overwhelming living with diabetes. So what is rewarding for me is the outcome of the education we provide them to make their life better. Many of us see patients with foot ulcer. First visit, they come with what we call open-toe slipper or Japanese slipper with their foot ulcer. After the education, the next visit, they come with a cover shoe. That is rewarding for me. Talking about family conflicts, I would like to share with you another story of my patient. A 62 years old man, he had diabetes for a long time and poorly controlled. So at 62 years old, he already showed signs of early dementia. A few weeks ago, he came for his follow-up. He came with the wife. The wife was very stressful. You could see the stress on her face. So I asked her why. She said she had to look after the husband, who is having some signs of early dementia, otherwise forgetfulness, very forgetful. Forget to take his medicine, so she has to look after his medication. But that is okay. Then she said that I have lots of sleepless nights, every night, because my husband will leave the house for exercise. He loves exercise, which is good for the people with diabetes. But he left the house for exercise at 4 o'clock in the morning. And sometimes he left the main gate door, he left the gate open at 4 o'clock in the morning. That really stressed her out. She said, how can I ever have a peaceful night of sleep? After much discussion, he agreed to exercise at 6 a.m. or after 6 a.m. A week later, I received a thank you text message from the wife because the husband now go for exercise at 6 a.m. when she is awake. So these are just some of the cases I would like to share with you. So we hope with education that we can work with the patient with diabetes to bring their life to a journey that is more peaceful, that is rewarding for them. And lastly, in the field of diabetes education, there is always a requirement of continuous growth to support the challenges faced by the patient living with diabetes. The main objective of diabetes education is complication prevention and quality of life, and improve quality of life for our clients. So we have to constantly update our own knowledge so that we can help our patients to find the solution of their problem. Just like in this pandemic of COVID-19, I mean, during all my years of training as diabetes educator, we don't have COVID-19. But now I have to learn about it. Related to diabetes management and COVID-19. And all my years of diabetes education, we usually provide face-to-face education. But now we may have to learn how to provide education by telemedicine. And to update myself with the continuous growth as diabetes educator, we can always do our literature search, do research, like what I have done for my master's degree, for my Doctor of Nursing degree, to answer the clinical question that we have when managing our cases with diabetes. So in a nutshell, why I stay in diabetes education for 33 years, and I can foresee many more years to come, is because I was very lucky to have the privilege given by the people with diabetes to walk the journey of their life with diabetes. In this journey, I may be an expert in diabetes education, but I'm not an expert of living with diabetes because I do not have diabetes. So together with the people with diabetes, we hope to turn their diabetes stress, their struggle, their barriers into action, confidence, and hope for them. Now,
excuse me, sorry to interrupt, Dr. Tan. We are running out of time, so
okay. I'll move fast.
Thank you.
Diabetes educator in COVID-19. Now, nurses, doctors are frontliner care for people with COVID, for the patient affected by COVID-19. But as diabetes educator, we are the frontliner care for people with diabetes. With COVID-19 and MCO, diabetes management, as you have heard me saying, that living with diabetes is very complex. But with COVID-19 and MCO, diabetes management has even become more challenging. Diabetes increases the risk factor, is an increased risk factor for more serious outcome of the COVID-19 infection. In the hospital, most of the resources are diverted to fight in COVID-19. So the standard of diabetes care is being disrupted, and which can cause a lot of effect on the high sugar level, low sugar level of people with diabetes. And generally, for us as diabetes educator, we practice the model, we call it AADE 7 self-care. It stands for AADE, stands for American Association of Diabetes Educators. The 7 self-care are healthy eating, being active, medication intake, and monitoring, risk reduction, and problem solving and healthy coping. But for this talk, I would like to rearrange them in order that we can meet the demand of looking after our patient in COVID-19. The most important thing, because diabetes itself is a risk factor. So it's very important, we must constantly remind our patient never stop their prescribed medication. If those who have, some of them may have access problem to medication, but in Malaysia, we are very lucky. The Ministry of Health, some private hospital actually provide postage and courier service of medication. And if you have a valid reason of traveling, the police do not stop you from going collect your medication. Under risk reduction, very important, remind your patient you should reduce their exposure to COVID-19 environment because diabetes itself is a risk factor for more serious complications. So stay at home, practice social distancing, and frequent hand hygiene. And we must also inform them when to call for help. Remind them about signs and symptoms of diabetes, ketoacidosis. For those with severe eye problem, foot ulcer, chest pain, they should come for early medical help. And globally, actually, we have noted that in the month of March and April, there is a higher incidence of death due to non-COVID-19, which the medical community thinks that it's because people with diabetes are so scared to go to A&E for when they have problems. So please remind your patient, if you have problem, go and seek medical help. And been in the MCO with the COVID-19, all of us are affected in some way, the psychosocial, the psychological well-being, such as stress, and so is people with diabetes, anxiety, depression. And more importantly, globally, including in Malaysia, there is an economic, financial problem for a lot of people, job insecurity. So our role is to encourage our patients to talk about it openly. If we think as a diabetes educator, we cannot handle their emotional problem, we should refer them to the mental health profession or the hotline that is offered by Ministry of Health and the NGO. And problem solving, how do we teach them problem solving? During COVID-19, we should advise them to intensify their metabolic and glycemic control to prevent serious diabetes infection. How can we do it? Direct text message to encourage self-care. Telehealth by healthcare providers, NGO to optimize diabetes care if they are not able to come to the clinic for their consultation or follow-up. This is something the Ministry of Health and some NGO are setting up for B40 population in Malaysia with diabetes, sourcing for information for them to solve their problem. Healthy eating. Having COVID-19, MCO, it really affects everybody's dietary habit. For people with diabetes, they still have to continue to support. We have to continue to support them with healthy and mindful eating habits, such as a few tips: limit purchase of unhealthy snacks. Now with financial problem, just concentrate on the 3 meals. There's a lot of healthy eating recipes being shared in the social media. There is another way. We also must encourage them to continue being active even though MCO has altered our daily schedule, restrict the outdoor activities. But as diabetes educator, we can always show them how to do increase their physical activities within the house, our own house, within our own compound. For ladies, for housewives, they can do spring cleaning, gardening, and some of my patients actually started planting vegetables. And they are very happy because after post-MCO, they'll get their own supply of vegetable. For those with exercise machine, they can continue their exercise. Those without exercise machine, there are a lot of online exercise classes. One of my patients actually shared with me is the 3 miles walk. She said every day after her work, she settled her son, she will be in front of the TV and doing this 3 miles walk following the instructor in the TV. And the last one is monitoring. Medical supplies may be limited, but in Malaysia, we are quite lucky because pharmacies are still open. In fact, my main concern is the financial problem. So as diabetes educator, we can guide our patient to do minimum monitoring that can still provide us with information that can be useful to guide them in monitoring their diabetes. Sick day management, we should give them information on sick day management. So the take-home message about diabetes educator and COVID-19 is people with diabetes are at a higher risk they are not at a higher risk of getting COVID-19, but diabetes is a risk factor for increasing the seriousness of the COVID-19 infection. So tell your patient, stay away from COVID-19, stay at home, practice social distancing and hand hygiene. And we as diabetes educator at this pandemic, we have to continuously support our patient, the family member, with all the diabetes care, the 7 AADE, 7 cell care, through social media, WhatsApp, telephone, text message, or face-to-face if there is a chance. And lastly, for all you in the audience, if you work with people with diabetes, and if you're interested to look for specialty to improve your career path, this may be a career path that you can try to go for it. And in the last decade, there is an increasing awareness of the importance of diabetes education in Malaysia. So a lot of hospitals are actually looking for diabetes educator. However, we are still very short of diabetes educator in Malaysia and globally. So our next speaker, Dr. Ching, will enlighten you if you are interested in this career path. Thank you very much for your attention. And I'll pass the floor to Dr. Ching now.
Thank you, Dr. Tan. And hello everyone, and thank you for taking time out in the afternoon to attend this live session. I'm Ching. I'm a dietitian by training, and I'm also a lecturer at IMU and the program director of the postgraduate diploma in diabetes management and education program at IMU. I just want to share with you why IMU decided to have this program at the postgraduate level, because I think when we look at what we do, and I assume that there's a lot of you who are in the audience who are actually healthcare professionals, and we are healthcare professionals because one of our reasons for leaving one of motivations for life would be to help patients, right? And we know in Malaysia, one, diabetes is a major problem, right? Statistics show 1 in every 6 Malaysians have diabetes, and it's going to get worse. Number 2, we don't have enough diabetes educators in Malaysia. There's a shortage of diabetes educators in Malaysia. And number 3, all healthcare professionals dealing with patients with diabetes actually need to upskill, because managing diabetes is very complex. We need to be skilled enough to walk alongside the patient living with diabetes, to empower the patient living with diabetes to manage their disease independently, right? So if we look at what is needed to manage the cases properly, and if you look at the slide in front of you, and is it yellow or orange? The yellow arrows, we actually need to be able to apply. We need to be able to analyze and evaluate what's happening with our patients, and then create individualized plans. And for that to happen, we can only do it through 2 ways. One, we either see a lot of patients and through time increase in our clinical expertise. So that's the blue line down there. So the more patients we see, the more case discussions we do, the better we become. Or 2, we fast track it, we do a postgraduate level education. So when we developed this program, we actually thought, do we do it at the undergraduate level? Do we do it at the graduate level? But we decided to do it at the postgraduate level, because it is at this level that you get to learn the skills to analyze, evaluate, and later on create individualized plans for the patient. So in this way, we become more meaningful in our care for patients. And I think that's just my message for today. Very short, very sweet. We have questions from the floor, I think, and shall we open the questions?
Okay. Thank you very much, Ming Yeong and Ching Li. I must say, as a toxicologist and a medical biotechnologist, if I could go back to school, I think I would be, I would get a degree in diabetes education. All right. Dr. Tan, you want to switch on your camera? Dr. Tan?
Incoming.
Yep. Okay, we have a very basic question. The first question is, how does one plan to get credentialed as a diabetic educator in Malaysia?
Currently, with a credentialing diabetes educator is usually awarded to a person who has undergone certain training of diabetes education. In overseas, in America, is awarded by the American Association of Diabetes Educators, so is in Australia. In Malaysia, currently, we do not have this accreditation board yet, but we are in the process of developing it. By doing just a postgraduate degree does not entitle you to be a credentialed diabetes educator, because globally, there are 2 very important things. First, you must have a postgraduate degree. Second, you must have at least minimum 800 to 1,400 hours, previous hours, in the field of diabetes education. So these are the 2 main criteria.
So your advice is to try to get the degree abroad?
You either get it, wherever you get the degree, but it's important it should be a postgraduate level, because at postgraduate level, you actually apply, analyze, and evaluate the situation. Instead of an undergraduate level, you just understand, try to remember, and just follow the instruction.
Okay, so for the person who asked that question, I think it's also important, as what Dr. Ching Li had mentioned, this particular program, if let's say you're a pharmacist or a optometrist or somebody like that, who would like to have a little bit more information on diabetes education. And Dr. Lee, please come in to respond to this question as well. Would this be a viable course for these professions to upgrade themselves and to actually have an impact on their patients who actually have diabetes as well?
Yeah. Okay, I think just to extend on what Dr. Tan has shared and also the question that Prof. Chin has asked, the situation in Malaysia is such that we don't have a credentialing process yet, okay? So to become a diabetes educator, you first have to get the necessary training, right? So you can do that with a postgraduate degree. And anyone can do that. Now, when we developed this program, we actually looked at the available programs around the world as well that churn out diabetes educators. Okay, and we noticed that a common factor would be they are limited to who can participate. So maybe they're just limited to nurses, or this is specifically for doctors. But the situation in Malaysia here is that when you talk about frontliners for people with diabetes, it's not only just nurses, it's not only just doctors. We have pharmacists in the hospital, pharmacists in the community. We've got dietitians, we've got nurses, we've got doctors, we've got MAs, we've got podiatrists, we've got a lot of healthcare professionals who are out there seeing patients with diabetes, and we need to upskill these people, right? So one way to do that is to take this degree or an equivalent degree to upskill. And in Malaysia, if you take a program that is recognized by the government, so in this case it's NQA, then it's recognized, your degree is recognized, you can call yourself a diabetes educator, you can function as a diabetes educator, but you are not a credentialed diabetes educator. So say, for example, like myself, I'm a dietitian, but I've got no formal background in diabetes education. So whatever I've learned has come from years of practice, a lot of case discussions, combined clinics, presenting, research. So I see patients with diabetes. In running this program, I learned a lot about being a better dietitian. I've incorporated some aspects of being a diabetes educator. I actually do have plans to get a degree in diabetes education. And if I'm going to continue practicing in Malaysia, I won't think about credentialing myself because that is not really needed. But I will clock the hours, because let's just say if I'm going to practice in Australia, then I might want to get myself credentialed in Australia. And I think, Dr. Tan, correct me if I'm wrong on this, the difference between the credentialing and the non-credentialing is the hours, right? You have to really show that I now know and I practice and I see patients and my patients have improved as a result of what I've done. And I need to continuously clock those hours to maintain my credentialing. Is that correct, Dr. Tan?
In some way, it is correct. But in some way, because usually a credentialing or a certified diabetes educator is somebody who is actually has already committed in this career path. So that's why they wanted your previous experience in this. But they are actually more than this. They are actually more than this. That hours is very important. I've been reading through most countries' credentialing program, and this is one of the requirements. Postgraduate training and your number of hours. And of course, there are other things that you may have to still undergone some, like Australia, they have the mentorship for 6 months before you can be a credentialed diabetes educator.
Okay, that's, which is actually very, very important to note. You know, the certification or credentialing is important. And like Dr. Lee was saying, the hours are important. However, now we're going to bring it back to the Malaysian context. We do not have this type of credentialing or program to certify people in Malaysia. So alternatively, what we can do best is the best of both worlds. You have the hours, like Dr. Lee was saying, and then you have the education, the foundation education, like what Dr. Tan was saying. And in order for, you know, dietitians or pharmacists or even optometrists and nurses to be able to manage diabetes in their profession, I think for right now, this is the only viable option, right?
Yes, for now, but we are working towards the credentialing board by the Malaysian Diabetes Educator Society. And we hope it will be rolling out in the near future, because every country have their own credentialing board. And can I just add in, diabetes educators are not limited to nurses. Anybody who work with people with diabetes, pharmacists, dietitians, clinical psychologists, social worker, physiotherapists, medical doctors, they are all qualified to be a credentialed diabetes educator.
But Dr. Tan, we're going to note here, we cannot say credential diabetes right in Malaysia right now.
Yes.
So let's go back. Let's remember now, Malaysia does not certify, doesn't give credentials for diabetes management. But for right now, this program is basically one of the ways to actually utilize your desire, your passion, like you've exhibited, which I must tell you, Dr. Tan, like I said, if I weren't a medical biotechnologist, I would be a diabetes educator as well. So this is one of the ways for, all the professionals who deal with patients or personal members in their family with diabetes. This is the best way right now. Okay, so the next question is very interesting. Blood sugar levels, blood sugar readings. I'm trying to integrate some of the questions. There are a few that, I'm trying to figure out what is the normal blood fasting sugar level? What would the expectations of blood sugar readings in the elderly or nursing homes? And also, what about how would you try to manage blood sugar levels during the fasting month? So I know I've asked a lot of segments in the question, so I open it to both Dr. Tan and Dr. Lee.
Okay, blood sugar level is individualized. There was a question about nursing home, elderly people. So there are different level of blood sugar level we give it. It's all individualized according to the person. So for an adult, and again for the elderly, depending on the functionality, whether they are demanded, whether they have any other problem. So again, in the elderly, it's very complex. Different, we actually give them individualized blood sugar level. If they are still functionally independent, mentally no impairment, their target will be the same as the younger adult. That is, for people with diabetes, you'll be between 4 to 7. I usually, or sometimes 6 minimum. That's why I say it's individualized. That is the fasting. And it is very important. What about blood sugar monitoring during fasting month? There is a lot of guideline in the internet. Usually very important. They have to monitor more often, especially depending on how much, again, depending on factors. If they can afford, they should be doing 5 tests a day. That is before sahur, after sahur, midday is the most important thing, because we want to make sure they are not having low sugar. And before buka puasa, after they have eaten their food, they should be monitored again. Actually, this is the minimum monitoring regime for fasting month.
Dr. Tan, I think just want to interject. I'm reading the comments as well, Prof. Ching. There's something about sugar readings as well and monitoring. I think you can answer this very well. For patients who, this is from MY, yeah. For patients who are unable to afford the 3-day consecutive fasting 4-point sugar for insulin adjustment, what is the minimum I suppose we can do? Can they just do 1 day?
Okay. It all depends on when you talk about insulin, what type of insulin regime they are on. If they are on basal insulin, fasting will be good, because that is what we use. The reading is the one we use to adjust their insulin dosage, for insulin dosage adjustment. If you are on twice a day insulin injection, I would say that fasting and before dinner, pre-breakfast and pre-dinner. If you cannot, if you have financial problem, even you can do alternate days for that. And after 3 reading, we are more or less able to adjust the insulin dosage.
Okay, so basically to summarize, for affordability in one day during fasting, the minimum testing will be 3 times, correct?
Ideally, it's 5 times, but minimum, sometimes I allow my patient to do it 2 to 3 times. But very important is the midday to 2 a.m. to 2 p.m. because there is a time, because they fasted a long time, whether they go into low sugar.
Okay, and also the diurnal cycle and all that factors in as well. Okay, okay. This is an interesting question. How do you have any advice for diabetes patients? How would you advise them to lose weight?
Dr. Lee.
MCO, makan control order. Weight loss, it's not very easy. I think for the average person, weight loss is a struggle because it's lifestyle based. It has got to do with your food intake, it's got to do with exercise, and maybe there could be other underlying medical conditions that make it a little bit more difficult to lose weight. And there are some people who think that, and we've got some evidence as well, but we're not so sure, that if somebody has diabetes, it becomes slightly more difficult. So we're not sure whether it's because of the disease itself, the condition, or is it because with diabetes, you have the extra burden of care. You've got so many other things to do. So weight loss just happens to be one of the additional things to do. So weight loss, I think if we want to help our patients with diabetes lose weight, and I think there's also a question down there right at the end, how can we prevent, there's from Tharchayani, she says, during MCO, maybe there are more people becoming pre-diabetic and diabetes. So the answer to that is also weight loss, okay? Quite a lot of people who convert from normal to pre-diabetes to type 2 diabetes, that happens through excessive weight in Malaysia. So if you can get them to lose weight, you reduce your risk of getting diabetes, okay? So weight loss, I think if we want to help our patients lose weight, we must first understand and show them that we understand that it's not going to be easy. So it's not as simple as, oh, you should eat less, or you should, right? And then how do you do that? Wow. You need a diet plan. You need to have an exercise prescription. And I think if weight loss is seriously on the cards, you got to relook at the medications. There are some medications that are that if we don't prescribe properly or titrate properly, can cause make weight loss difficult. So we want to get more weight-friendly medications probably. Well, that's my viewpoint as a dietitian. Dr. Tan?
Yeah, I agree with you.
Okay, I just want to summarize a little bit for our audience because you had a lot of information there. I'm trying to also trying to integrate what Dr. Tan had mentioned before in her talk earlier. Is every individual is different. Every individual is unique. So, and to integrate what Dr. Lee was saying, before you go on a diet regimen, you always have to consult a dietitian or a physician because, hormone-wise, we don't know what's going on. Exercise-wise, we don't know how it's going to play into it. So is that correct, right? Before you start off into something as extreme as a diet because you want to lose weight, especially for diabetic patients, it's better to consult with a physician or a dietitian before you embark on that journey, yes?
Yes.
Yes.
Okay. And also during this MCO, it's so much easier to grab your potato chips and your things that are full of carbohydrates. Why? Because it makes you happy. Right? And like what Dr. Tan was saying, hey, happiness is important. So if you eat to be happy, then the cycle repeats itself. So it's just one of those things that, really awareness of what it is, of what diabetes is. Like one of the questions, like how is awareness of diabetes in Malaysia? Because Malaysia is the top ASEAN country with the highest diabetes population, correct?
Yes.
And so currently what's going on with the awareness campaign in Malaysia? I'll open the question to the both of you.
I think awareness complaint that the Ministry of Health and a lot of NGO has done a lot of work. But I think what we are lack of is to evaluate what we have done. Because you can introduce something, does it work? The patient are fully aware. And it is not as simple as I give you the knowledge, you will do something about it. Diabetes, behavior change is more complicated than that. I mean, if it is just knowledge, it's easy. What say you, Dr. Lee?
Yeah, Dr. Lee, what do you think?
I fully agree. That's why when we developed the program, okay, I'm not selling the program, you know, but when we developed the program, we placed a very high importance in including topics like psychosocial care, you know, or self-care management, because it is not as simple as I prescribe you medication and then you go out. I think those of you who see patients will know this, right? You give the patients a prescribed diet, your medication, then they disappear for a while. They come back, adherence is limited. I think so. Behavior change is very important. So it's yeah, like what Dr. Tan says, it gets more complicated. We've got to really assess, analyze, evaluate what's happening with the patient, and then walk alongside with them. And I think empathy. We need to have a lot of empathy. We need to understand that patients live with diabetes. It doesn't go away. It's just it's one part of a whole lot of things they have to address in their life, right? We need to respect that, and we need to show that empathy and our care. Then our patients come back, right? And when they come back, and there's data to show when they come back, they're more adherent. We reduce their risk for microvascular complications, macrovascular complications, right? Yeah.
Yes, I remember what Dr. Tan was saying earlier, the three amigos, right? Hypertension, hypercholesterol, and diabetes. Is it the three amigos or something else? Can't remember. And out of the three, diabetes is the only disease that you can pop a pill because it doesn't work that way. And there are a lot of confounders that are factored in, like what Dr. Lee was also saying. It's the social interactions, the engagement, it's the understanding and the awareness. Popping a pill or injecting yourself with insulin, it's not going to do it. And it's going to take a lot of support that goes on beyond the inner circle. It's in the environment as well. Because we don't want to go on the street and you have this 7-Eleven advertising, oh, the big gulp, you know, it's like 200 milligrams of sugar in one drop. So, you know, things like that doesn't help. And so it is really awareness in the community as well as personally as well. I think I'll have time for one last question. And this, I open it up to the both of you as well. Why isn't there a cure for diabetes?
Oh, this is $1 million question. Whoever found it will be the millionaire. Unfortunately, the truth is we haven't found a cure.
But okay, just to share, no cure at the moment, I think. I think maybe give us enough time. I don't know, with biomedical technology, perhaps can replace pancreas. I mean, there's so much technology can do. But reversal of diabetes is what some people say is possible, and that links back to weight loss. So if your patient has diabetes, has a huge weight problem, if we can bring the weight down properly and sufficiently, we're talking about 10, 12 kilos, I think, or 15 kilos, and there are trials to show that it works, right? You can actually reverse diabetes. So you can bring your patient's blood sugar control back down to a state where they do not need to control it using medication, just lifestyle. So it's possible. And in laboratory studies in rats, if you fast the rats enough, you actually have beta cell regeneration. So while the future seems, you know, bleak right now for patients, like there's no cure, but I think if we continue to push our centers of care, we continue to do research in this, one day, you know, we just push the boundaries of care and just maybe one day there's a cure for diabetes.
I think just to add on to what Dr. Lee has said, remission of diabetes has to be done early, in the early stage of diabetes, not somebody with diabetes for 10 years, 15 years.
Yes.
But that is already shown. That's why weight loss is so important.
Yeah, historically, I remember I attended a talk way back last year. I think Dr. Lee was there. We had someone come in and talk about in the pre-insulin injection days, controlling their diet was the best way of overcoming diabetes, correct? And we may have to have a happy marriage between that and the possible treatment and management right now until a cure. I don't know whether it's possible. I hope it's possible until a cure has been procured. Okay, so I think we've gone way over, but I'd like to have Dr. Tan and Dr. Lee have the last word before we tune out. Any recommendations, any words of wisdom? Dr.
Tan? Okay, to the audience, I think it is very important, if you are working with people with diabetes, please see the people first before you see their diabetes. And in the COVID-19 pandemic, I think it's important to inform them to stay away from COVID-19. If you are interested in this field as your career, I would strongly encourage you to pursue it because it's so rewarding. That's why I'm still in this field after 33 years.
Thank you, Dr. Tan. Dr. Lee.
I think, Dr. Tan, we may have twin minds, you know. Definitely put the patient first. It's always people living with diabetes. I always remind myself that because they're living with diabetes, there are other things in their life as well. So in that way, I think the patient, the healthcare provider-patient interaction becomes a little bit more empathic, and patients come back. It's very important to keep the patients coming back for follow-ups, not because of the revenue it generates, but because we are actually helping to reduce complications and, you know, extending the quality of life. So patient first, that's it. And yes, if you do have a passion for this field, please come. We need a lot of people. 1 in every 6 Malaysians have diabetes. If we don't do something about it early enough, I don't know, it's going to be massive. The fallout is going to be massive. So we need a lot of people out there. And yeah, just upskill yourself. If not through some official program, maybe just go for CME, CPDs, just read. Talk to us, you know, if you've got difficult cases, just email us. And then we also like cracking our heads, you know, how do we solve this case? How do we better care?
Yeah, I mean, thank you for your pearls of wisdom. I'd like to close by telling everybody, you know, thank you so much for attending this live talk. And for right now, there is no cure for diabetes. And at this rate, not for a long time. So in order to manage and treat diabetes, I think, you know, what these two ladies have discussed very poignantly and with passion, that it really takes, you know, a lot of hard work in educating oneself, you know, because everybody is unique, everybody's hormonal interactions are unique, and everybody's eating habits is unique. And this MCO and COVID-19 actually just threw everything out the window, correct? So what we're trying to tell you is, you know, just be wary, and there will be no cure. So in order to manage this, we educate ourselves with this particular diabetes management program. So I encourage everybody to continue with your questions. If you don't have a chance to put it in the chat box, please email it to us, and I'm sure Dr. Tan and Dr. Lee will respond to it accordingly and post it on the link. Okay, so thank you very much, everybody. Thank you, Dr. Tan. Thank you, Dr. Lee.
Thank you.
So we're out.
Thank you, everybody.
Bye.
Bye.